Hi everyone and welcome to today's webinar. My name is Lori Chelius. I've been working with Sophia on the CIN and she was unable to host today's webinar. Today's topic is reducing inappropriate emergency department use, and we're going to hear from representatives from both Monarch Healthcare and Humboldt Del Norte IPA, and they're going to share with us some of the exciting work that they've been doing in this area. Just a couple of quick housekeeping things before we get started. First, the session is being recorded. The slides and the recording will go up on the website in about a week or so. Also, if folks could please just mute phones and send things to voicemail, etc., and no hold music, please. We will be having everyone on mute, but just in case we need to unmute anyone at any time, it will just reduce distractions. So that would be appreciated. Today's speakers, we have Dr. Alan Glasroff from Humboldt Del Norte IPA and Dr. Michael Weiss from Monarch Healthcare. Just a couple words about them before we get started. Dr. Michael Weiss is going to start first, and he practiced general pediatrics in South Orange County for over 20 years with Southern Orange County Pediatric Associates, a 12-physician, 4-office pediatric group. Dr. Weiss is currently the Medical Director of Quality and Performance Improvement with Monarch Healthcare, a large Orange County IPA. He is the past president of the Orange County chapter of the American Academy of Pediatrics and serves as the chair of the chapter's Committee on Fitness and Nutrition, as well as the Medical Director of the Healthy for Life program and Fitness and Nutrition Intervention for overweight children in Orange County. Dr. Weiss graduated from the University of Michigan and completed medical school at the Western University of Health Sciences in Pomona, California. He completed his pediatric internship and residency at the Children's Hospital of Los Angeles. Dr. Weiss lives in Orange County, enjoys running, kickboxing, and golf, and he has been married to his wife, Lynn, for 26 years, and they have 2 sons who are 22 and 24. So we'll hear from Dr. Weiss in just a few moments. And our second speaker today is going to be Dr. Alan Glasroff, and just a couple words about him before we get started. Dr. Glasroff received his Bachelor's of Arts degree in History from Swarthmore College in 1974 and his medical doctorate degree from Case Western Reserve University in 1978. He completed his internship and residency in family practice at the University of California, San Francisco in 1982. He moved to Humboldt County with his wife and practice partner, Dr. Ann Lindsay, in 1983 and established a small-town rural family practice, which has been maintained for the past 26 years. Dr. Lindsay and he met in college at Swarthmore and married in 1974. They attended medical school, residency, and have practiced together ever since. He began work with the local Foundation for Medical Care in 1994 as medical director, developing a managed care infrastructure and serving as chief medical officer for the Humboldt Del Norte IPA since its inception in 1995. Dr. Glasroff is the principal investigator for the Humboldt Diabetes Project and served as president for the California Healthcare Foundation's Leaders Group for 2006 and 2007. He is the co-director for the Aligning Forces for Quality Humboldt Initiative sponsored by the Robert Wood Johnson Foundation. He has also served as faculty for Diabetes Collaborative for the California Academy of Family Physicians and Breakthroughs in Chronic Care Program for the Pacific Business Group on Health and for the Institute for Healthcare Improvement on various projects. He served as chair for California's Pay for Performance Initiative Technical Quality Committee 2007 through 2009 and also serves on the steering committee for the Integrated Healthcare Association. He served on the NCQA Patient-Centered Medical Home Advisory Committee in 2009 and 10 and currently leads a statewide Blue Shield of California initiative to reduce avoidable emergency department visits called Stop Avoidable Visits to the Emergency Department. And Dr. Glasroff was also named California Family Physician of the Year for 2009. Just quickly, before I pass things over to Dr. Weiss to get things started, we're going to have some time at the end of the presentation today for questions. So if folks have any questions, they can type them into the chat box on the right-hand side of the screen. If it's just a logistical question, you can send it to the host only. If it's a question for the for the speakers, you can send it to everyone so people get a sense of what's being asked. You can also raise your hand, which is on should be the right to the right of your name. There's an icon there. You can only do that if you dialed in to the phone after logging into WebEx, and we can identify you. If there's any questions on that, you can always just use the chat box. So let's get started, and we'll hand things over to Dr. Weiss.
Pretty intimate, and also I'm not entertaining any questions or jokes about the University of Michigan's football team, so we'll just put that out there right away. Let's see, do I have the right slides up? It looks like everything's cool. So I'd again like to thank you for having me, and I would like to just acknowledge, right away that there are so many nuances to each network's situation, and the things that I'm going to discuss here are certainly not a one-size-fits-all. But I do think that I'm going to try to hit some practical tips that may help many of those in the audience to achieve their goals with respect to ER. We all struggle with this. There are so many challenges at so many levels, the patient level, the provider levels, geography, coverage issues, all the different things that we deal with. But I think that there, again, are some universal themes that we can use to help to improve. So I'm going to go through some of the things we learned through the CQC Efficiency Collaborative that we joined in 2008, how we created an infrastructure at our organization to attack this problem and others, which I'll tell you about, and how we support our physicians and our patients in this endeavor. Just very quickly, for those who don't know about Monarch, we are an independent practice association in Orange County, covering all of Orange County. We have about 2,400 doctors, primary care and specialty care, that for the most part are in independent practice out in the community. So we are not a staff model HMO. We have practices ranging from one provider where they calculate their bills with an abacus to provider groups of 40 and 50 that are highly sophisticated on EMRs. So it's a wide range, and I'm sure many of you in the audience experienced that as well. We have all product lines and contract with all of the health plans, and we have agreements with over 20 hospitals in the Orange County area. And again, like many of you, we struggle with lack of exclusivity, varying amounts of engagement from provider to provider, and varying resource use within our network. There's the picture of us where all those little dots is, that's all of our patients. So in 2008, as I mentioned, we were fortunate enough to get involved with the CQC Efficiency Collaborative. And this was really revolved around appropriate resource use. And entering the collaborative, we had the opportunity to put together a program around either generics, ER usage, or ambulatory surgery center use. And we selected ER use because it was one of those areas where we were, frankly, struggling, and we felt we had a great opportunity. The goal was really to create a replicable model for improvement, and the key really was forming a multidisciplinary, cross-departmental team. So we brought together members of our provider relations team, our information technology group, people from decision support and analysis, as well as obviously many of our clinical staff. And it was physicians, it was nurses, it was dietitians, and it was support staff really across the board. We really made this a very highly visible, highly accountable group because it was a tremendous amount of time, and we really were tasked with analyzing the variation in our data and engaging our physicians and our patients in the process so that they would have skin in the game and we would be more likely to succeed. So really, empirically, we all have ideas why ER use is so high, but we really have tried to not be empiric in our approach, tried to be as data-driven as possible. So we started with a physician focus group, brought in a bunch of our doctors. We held 2 90-minute sessions. One was a pediatric group of physicians, one was an adult physician group, representing both high and low performers in terms of ER use of their patients, representing our wide demographic, both North and South Orange County. And we explained to them that we were really looking to meet the triple aim, high quality, lower cost, high patient satisfaction. And we wanted to look at underuse, misuse, and overuse of medical services, and what could they offer to us in terms of some insight as to why these things may be happening. We presented them each with single-blinded variation data, and then we showed them variance curves across our entire network. And really what we gleaned from this were some things that we already knew, but there were also some things that we didn't. Certainly access and availability of both primary care and urgent care offices was a major deficit. Patient knowledge deficits about when to go where and why. One thing that jumped out at us, which was a tremendous oversight, was misaligned incentives. We actually found that dating back to the beginning of Monarch 17 or 18 years ago, we had required that patients receive an authorization to go to the urgent care, but did not require an authorization to go to the ER. So after we dropped our jaws and knocked ourselves on the head, that was fixed very quickly. The docs also complained about the lack of real-time ER notification. Hearing that their patient went to the ER 6 months ago is really not of much value. And then they were really asking for support for some of those higher risk patients that were using the ER a great deal. So as a result of this focus group, we put together a structure to try to really attack many of these issues. So we started with an ER steering committee that really had oversight, setting goals, monitoring progress, looking at existing programs both within our organization and at the health plans to identify synergies and avoid redundancy, and then to do some reporting. We assigned project groups to many of these areas where we identified challenges. Member education team was tasked with putting together brochures and mailers, putting together an approach to post-ER phone calls to patients. Physician support team was tasked with identifying the physicians that we needed to go out and visit with one-on-one, how we would do that, providing the variation curves in terms of utilization, and looking at creation and provision of the physician support tools that we were going to provide. Urgent care team looking at our current network, where were the gaps, where were the areas for improvement. Reporting team was all the IT, bonus reports, variation reports, data analysis, and then a hospital team, and this was kind of a little bit of an aha moment and maybe one of those little take-home messages for the discussion. We actually went out and engaged an associate medical director of emergency medicine. So we really had never gotten the perspective of the ER docs, and it was actually very helpful because the ER docs don't want to see runny noses and colds, and they don't want to see sprains and strains. And even in this world of still economically driven medicine, they really want to do what an ER doctor should be doing, and that's deal with emergency situations. So the ERs were actually quite collaborative with us in helping to educate physicians and patients. And then obviously we needed their help in real-time data regarding visits to the ER. So we also needed to develop these physician strategies, and probably the most effective strategy was one-on-one visits to identify root causes from the physicians. And I would say personally the most valuable piece of the CQC Collaborative for me was around this, and any medical directors or provider relations people on the phone know the challenges we all face in going out and speaking to physicians regarding clinical care and variation in care. We were fortunate enough to be exposed to Howard Beckman, who comes from Rochester, and I think he actually left Rochester not too recently, or fairly recently. And he is really an expert in how to have those conversations. For those of you that have experienced Howard, he is not only very bright, but he is my antithesis. He's very laid back, very mellow, doesn't get flustered, speaks slowly, and really is the perfect guy to learn how to have these conversations from. So what we learned in the collaborative and what we took out to our network was keeping the visit very simple, number one. Number two, bring food, always important. Number three is listening, which is sometimes hard for those of us in the medical director and provider relations world, but you'd be surprised how much you can accomplish by just listening to these docs. Looking for opportunities for improvement, presenting it really as a non-accusatory visit, but really a productive, constructive visit where we are there to offer them tools to improve, and really making sure that the data that they get is actionable. So let me talk briefly about the data. This is really probably a huge, one of the most huge examples of you get one shot at this or you're done. If you bring data out to these doctors that is inaccurate or non-actionable, you're done. We learned that early on when we made some mistakes in the data, those doctors immediately shut off. Immediately, feathers were ruffled, and it was just not something that was beneficial. So another take-home lesson that I would write down is be very, very sure that your data is accurate. Use focus groups of physicians to vet that data before you start taking it out publicly, and I think you'll be much, much more successful. The other thing is when you bring the data out is keep it simple. They do not like to get stacks of 40 pages of information. With that said, though, most of the doctors will ask, okay, which patient was that went to the ER? So what we did is we brought out very, very simple variance curves, which I'll show you examples of in a minute. But in our back pocket, we did have the comprehensive list of their patients so that they could review that list and use that as an actionable piece moving forward. So some of the things, I have some examples in these slides of some of the pieces that we brought out. And the line above the yellow highlighted line, actually, I should have highlighted that as well. To present an ER utilization report for a year of visits is pretty worthless. So one of the first lessons we learned was to try to bring them the most recent data that you could. And as we all know, this can be a struggle with claims lag and that type of thing, but bringing them the most recent data is really very, very important. Other things that we learned in bringing these things out was we removed patients from their ER list that had been admitted to the hospital. This came from the physicians in the focus group, and one could argue, and we could argue this till the cows come home, but one could argue that if a patient is admitted, that's a proxy for an ER visit that likely was necessary. We also added direct verbiage, as you can see in the bullet points on this slide, regarding what we expected them to do with the report, rather than just throwing a big pile of stuff at them. We added specific targets and trending information, which I'll show you. And we really honed in on avoidable ER visits. That was a big aha moment for us as well. And defining avoidable ER visits is certainly a challenge. I can share with you maybe during the Q&A some of the things that we did there. But if a patient comes to the ER with a documented MI or a severe trauma, to tell the doctor, we really want you to cut down on your ER visits is a very difficult conversation. And then we honed in also on the frequent flyers, those patients that were being seen in the ER 3, 4, 5, 6 times a month, and made direct contact with them and called that out to the physicians. The next slide is an example of what we would present to the doctors, one of the pieces that we would present, and this is really kind of a variation curve. And if you follow the bouncing ball, this physician, let's look at the far right, June of 2011. The green was his actual number of ER visits or ER visits that were attributed to that physician, and these are avoidable ER. That's why the numbers are low. The blue is expected, and so what we did is we looked at whether these were physicians caring for children or adults. We looked at whether they were large, medium, or small panel physicians, which we defined, and we looked at whether they were in the north of Orange County or the south of Orange County. So we really tried to control for the group of patients so that the physicians would feel comfortable with the comparison. And so, for instance, this physician's patients were accessing the ER 1.29 times more commonly than would be expected given his panel size, location, etc. So we found this to be a real valuable tool, and the physician's response to it was actually fairly positive. The other thing that, as I mentioned earlier, we focused on was looking at those avoidable visits, and this is an example of focusing on the avoidable. So if you look at the 244, that was the total number of ER visits for that doctor's patients. 198 was those that were felt to be unavoidable, but clearly there were 46 or so visits that were felt to be avoidable. And so focusing on those avoidable visits, we really found to be valuable. We also, as I mentioned earlier, felt that it's extremely important to not just point out to them what the problem is, but we needed to point out potential solutions. And so some of the things we did, we created a very comprehensive urgent care list, which I'll talk about on the next slide. We reiterated to them the availability of our case management program and brought them the specific information how to refer patients into case management, those challenging patients. One of the synergies that we found when we were looking at the health plans and other resources is, we all know the health plans have these health nurse advice lines, and they're tremendously underutilized for a variety of reasons. So we were able to provide our physicians with those numbers so they could be provided to the patients. And then we worked with them on ways to provide advanced access, how to look at their appointments for the day, how to assess appointments by day of the week where they can open up same-day appointments. We even were able to bring some of our practices together to share in doing evening hours, weekend hours, that type of thing. So some of the strategies for members, I think this was obviously challenging as well, but one of the first things we did, which was very enlightening, is we started calling patients the day after they went to the ER. So when we would get that information from our local hospitals, we would call them, and we actually created a survey and put together some data and basically said, just curious, why did you use the ER? And what was your experience in the ER? And interestingly, some of the answers were predictable. A lot of the answers were things like, my doc couldn't see me for 3 weeks, I work until 6 p.m., I'd rather go bring my book and get my labs, my x-rays, and my meds and go home. And some of the patients actually did come up with some things that were surprising. They didn't realize that there were urgent cares. They didn't realize what the scope of services in an urgent care were. They didn't realize that some urgent cares could provide, fairly high levels of care. And with that all said, the 80-20 rule definitely applies. There were some who said, no matter what you tell me, Monarch, we're going to go to the ER because that's where I get what I want as quickly as I can get it, and I'm happy with that. So despite those 20%, we trudged forward, and we provided those members with information on accessing the urgent cares. This information was provided in new member guides. It was on our website. We provided, particularly for the pediatric population, what to do when your child is sick. And here's another little take-home I'd probably write down. One of the things that we did on the urgent cares, we had about 40 to 50 quote-unquote urgent cares listed on our website when we entered into this project. And when we reviewed them, about half of them actually were just primary care offices open Monday through Friday, 9 to 5, that did not provide any advanced services. So we immediately stripped those from our urgent care list. And then we went through kind of a painstaking process of calling each of our urgent cares and determining exactly what their hours were and exactly what types of services they offered. So did they offer x-ray? Did they offer lab? Did they offer casting? Did they see children? Did they provide IV fluids? these types of things I think were very, very important because our providers, when they were referring to urgent care, would pick an urgent care based upon the services that they provide. And we created, if you're familiar with the Zagat restaurant guide, where it has little footnotes underneath each of the restaurants, we put together a very similar guide where we indicated each site's service capabilities. And the feedback on that was very, very positive. Additionally, pediatrics, as we all know, is a very high driver of evening and weekend visits. So in our southern Orange County area, there was a program created called Kids Doc. And Kids Doc was a pediatric physician and nurse practitioner manned clinic that's open 5 p.m. to 10 p.m. During the weekdays and 9 a.m. to 10 p.m. weekends, also open every holiday, and they provide pretty much everything that is necessary for pediatric urgent care: breathing treatments, Rocephin injections, strep tests, urine cultures, things like that. And the response to that was also tremendously positive. One specific example that was very beneficial for us with respect to the urgent care issue was we looked to see where most of our ER visits were occurring, and we were able to find 2 or 3 community clusters where a lot of ER visits occurred. And so we looked at the urgent cares in those communities, and we actually went out with them, met with them one-on-one, and offered them the opportunity of co-marketing as kind of a carrot to increase access to these urgent cares. And this piece that you see on the slide is actually a refrigerator magnet that specifically markets this one urgent care. We had a tremendous response to this, and I'll show you some data here. This is basically looking in the green is patients who received the ER magnet, and the purple is patients who did not. And we saw, believe it or not, in the 6-month period following the mailing of the urgent care magnet, a 40% reduction in commercial ER utilization in that geographic area, whereas those patients who did not receive the mailer, as the purple, showed an increase in ER usage. So you can see down the road in all of the lines of business, we saw a trend downward in ER utilization. So in looking at urgent care utilization, during the same time period, same parameters, either receiving or not receiving the mailer, interestingly, we saw the same situation except in the senior population. And if you think about it, it actually kind of makes sense because the seniors tend to have more severe chronic issues and from our experience, less acceptance of the urgent care approach and really wanting to access emergency rooms. So really, to kind of summarize many of these points, the success is really going to require a multidisciplinary approach. It has to be a high priority within the organization. You have to foster collaboration across all entities within your business and also outside of your business, so physicians, patients, and facilities. It can be very resource intensive, but the return on this is very high. As we all know, decreased ER use, decreased admissions, increased patient satisfaction. The keys really are actionable data and really working on that approach to how you speak with the physicians. I can't emphasize that enough. I know there are many, many medical directors and provider relations staff on this line, and I cannot emphasize enough that you can have all the greatest tools in the world, but if you go out and the conversation is not appropriate, it's not going to work. And I would, do everything within your power to engage consultants or, call Howard Beckman, for God's sakes. I know he does this, as a consulting job, and I don't get a kickback from Howard, just to be clear. But learning how to have those conversations, I think, is extremely, extremely important. Incorporating your providers in the process, extremely important, or else they're not going to have skin in the game. And it really does work. I think if you provide the proper education, have those conversations appropriately, and provide them with the tools to improve, you will be successful. So I think that's my 15 minutes. I'll gladly pass this off now to Dr. Glasseroff.
Great. Thanks, Mike. We're just going to switch the presenter roles right now. So, Alan, if you could just bear with us for a second while we do that. If you see, should be a tab at the top of your screen with your slides on that. Perfect. Great.
And can you hear me?
Yes.
Good. Okay. So this is my story has a lot of similarities to what Michael just talked about, and I thank him for what I think is a really excellent presentation. Our environment is very different, but a lot of the approaches were somewhat similar, but influenced by the geography and the nature of the community. And you know, let me just start by telling a little story about what it's like to live in a rural place. When I moved to Humboldt County in 1983 with my wife, we had to choose between living in the big urban center of Arcata, you know, which has 12,000 people, or live in southern Humboldt, which is a tiny community. And one of the determining factors was in southern Humboldt, if you were a doc at that time, you had to basically be on call in the emergency room because they didn't have a doc there 24/7 ready to see patients. So if someone with poison oak showed up at 2 o'clock in the morning, a tourist, your job was to get up, you know, get in the car, drive down the mountain, and see them at 2 a.m. And then, you know, so I thought that was a little radical in terms of expectations of life. So I moved to the big city where at least they had 24-hour emergency room coverage. You know, it's kind of a different view than Orange County, I think. And consider that as sort of a backdrop as I get into the topic I'm going to talk about. You know, Michael used the concept of triple aim, and we actually, in this work, joined a triple aim action community that IHI set up around avoidable ED visits that ended up having a lot of similarities between what it did and also what the CQC Efficiency Collaborative did, though getting there in perhaps different ways. And I don't know how many people have been following the California Healthcare Foundation's innovation activities that are going on right now. And they're using a model that is sort of, could be called sort of patient-driven or patient-centered design or people-centered design. And that's very much consistent with what IHI does. And so the first thing you always do with IHI, you know, you figure out how do you get the will assembled. And you do that by starting with a mission that you can define and measure. Then you need to figure out who do you need to bring around the table to develop the will and the wherewithal to actually solve the problem. And very often efforts are derailed by lack of senior leader support. So you have well-intentioned, hardworking people in the trenches trying to solve something, but it's not valued by leadership, and you're really not going to get very far if you don't have that kind of backing. Then the next step was figure out what you're talking about, and for IHI, it isn't that one size fits all. It's that there are a lot of different types of patients, and you have to figure out what you're trying to solve. In this national learning community that we were part of, and it interestingly enough included two from Canada, one in Ontario and another in British Columbia, large cities like the city of Milwaukee, and also Montgomery County outside of Washington, D.C. Most of the other groups were there because some subset of their patients, not the Canadian groups, but the American groups, some subset of their patients didn't pay very well in the ER. And so they were trying to come up with strategies for the people that the county was really on the hook for, or the city was on the hook for, because the hospital would see these unreimbursable patients using the ER for primary care, and then go to the county for funding to support that. And that was clearly their goal. In Canada, we found that we had more in common with them because really we were trying to not just lower the ED rates for HMO patients, which is what we were charged to do in terms of our business model, but really look at the issue community-wide, because it turns out our provider base, and I'll show you that on the next slide, takes care of the entire population of Humboldt County, which is 130,000 people. So we were looking for sort of global solutions to things. So then once you get to identifying the types of patients, and you do that by analyzing data, and a few other activities which I'll discuss, you then have to get down to who actually can get the work done. And that turned out to be a group that was different than what we expected, and I'll speak to that. But if you go back to Michael's slide, not that I want you to look at it right now, but remember the organizational diagram. That was essentially the refined coalition approach. You know, you need a member relations, you need, the hospital was brought in because they were helpful, and you basically end up assembling the parts that might be helpful in the work. And then the goal is to come up with strategies and test them, and then try to turn them into tasks, if they're valuable, to sustain lower avoidable ED admissions in an ongoing way. So, did I skip one? Oh, no, I didn't. Okay. So, a little bit about building collaboratives, and a lot of you have probably been in collaboratives. It's a mixture of, assembling people around a core vision and a set of core principles, stepping into the work collectively, and then using the model for improvement to figure out the changes that you're making, whether they actually work or not. Ultimately, you're trying to take tests that you're experimenting with, deciding whether they're worthwhile, and then turning them into tasks that become, that you can measure how reliably you're doing the task in the future. But you don't need to keep testing for the rest of your life. Your object is to get a set of things that you know work, and then the job is to do them reliably. So that's kind of what our goal was in the whole thing. A little bit about Humboldt. There are only 7,000 managed care lives in the county. About another 3,000 self-insured lives that Humboldt County, that the IPA, or the Foundation for Medical Care, a sister organization, runs the health plan. So that gets you to about 10,000 out of a population of 130,000. The rate for the HMO going into it was about 161 per thousand per year, and the state average in 2008 when we began this work was about 117. Interestingly, there was only one urgent care center in the entire community, and I'm sad to say it's about to be closed as the hospital is building a new tower and decided that 22 emergency room suites were more likely to pay off the new tower than an urgent care center. So the single urgent care center is about to close. So that's not a good solution for us, and never was, in terms of there only being one. The geography of Humboldt is the size of Connecticut, so you can drive for 2.5 hours and still be in the county. So that's a long distance for some of the people to travel to get to the one urgent care center anyway. Very pretty place. You can see the cute pictures on the bottom. Anybody wants to visit here, I highly suggest it. So look, again, starting at data, and this is some of the early data. We actually got this data, I think, from Blue Cross Anthem in the remote past of 2007. And it tells you what day of the week patients show up. It also tells you by the age group who is showing up. And we were able to use this data to kind of guide us. There's a kid problem in the 1 to 4-year-olds, and there's the young adults also go to it fairly frequently, and then there's sort of another spike in middle age. But each of them have their own stories and explanations, and I'll get into that. We sat around and did a brainstorming session as sort of the very first thing, and tried to sit around, much like the focus group that Michael did with the docs. Ours was multidisciplinary, but it was just, what might get in the way? Why would people be showing up at the urgent care center? And we came up with this list, and for those of you who are familiar with fishbone diagrams, they're a way of kind of brainstorming what might be at play. and then you can go through a process to try to figure out, what's the 20% of the activity that accounts for 80% of the action. So this is a step we took. And you can see above the horizontal line, it has to do with access. Lack of urgent care is obviously a problem. Clinicians can be a problem in terms of choosing calm schedules during the day over squeezing patients in. Office staff have often been trained to be walls instead of sieves, as to use the old ER terminology from my training. With protectionist behavior, their job is to say no. The back office might be really inefficient, not triaging phone calls well or even receiving them. And then another thing happening in our county was that the local hospital was massively advertising their emergency department as a great place to get primary care. And billboards outside the airport, it would be one of the first things you'd see upon landing in Humboldt County by plane. On the bottom, it was, what are the patient factors? And, when you talk to the docs, they're all about these patient factors. People manipulating the system, in drug-seeking behavior. They're lazy, and they go for convenience. And then there are sort of more legitimate reasons, which are, people are being turned away from their doc when they do call and are referred to the ED. They can have acute serious problems where ED is absolutely appropriate. Every phone message when you call a practice says, if you are having an emergency, hang up immediately and dial 911. So there's that to deal with. The patients can be taught to go to the ED by earlier experience, being turned away by the practice when they call. All of these things could have been factors, and we considered them all. But then we did what IHI is really known for, which is, why don't you go actually talk to patients about what their experiences are? And we went to these interviews asking open-ended questions by phone. We were generally, in the beginning, because we didn't have any timely data, talking to people who had been to the emergency room somewhere, 3 to 6 months previously. So their recollection of why they had gone might not have been as pertinent as it might have been. But what we found out was fairly convincing on our end, in that the patients were by and large making the best decision that they could based on the information that they had. That they're pretty good problem solvers. We asked them questions such as, when did you know you had a problem? Who did you go to for advice? And what we heard is, the neighbor down the street had 1 year of nursing school, so she's the go-to person in the neighborhood. Or, my niece is an LVN who works in the nursing home, and I go to her. Those are the kind of information. What was pretty striking is it wasn't call your primary care doc for information. These interviews were a real eye-opener for our staff in terms of what was going on. And out of that, what we did was, and looking at the data and looking at the stories, we worked on this concept of patient stream. And I threw up a little graphic of a river delta, because you start off with the Mississippi rolling in, which is this ER number per thousand per year, but then it starts sorting itself out into different groups, and you can create a patient stream in multiple ways, but there are certain characteristics that it has to have to be useful, and the main one being it has to occur often enough that you don't have to wait 3 months to get the next patient who fits that stream. That it's something happening regularly. So, and because it's happening regularly, it's important to you. And also that it could be based on diagnosis, it could be based on demographics, who they are, how old they are. It could be based on geography, the patients of one town. It could be based on insurance type. But you had to carefully sort out what you were looking at in order to have intelligent interventions and tests to make for each of the streams. And I think, obviously, Michael did similar things in his work. They sorted by region and they sorted by age group, and we did similar things. So we came up with 6 streams, and I'm going to largely confine what I'm talking about to one of the streams, the first one. But all 6 of these had different answers and different issues. And just if you look at them, you know, obviously we're incentivized to reduce visits for HMO members. We're being held accountable for that number. We receive shared savings money from health plans if we control it well, though we're not globally at risk as a county. PPO is a whole different story. Their patients may not have primary care. They may not have assignment, but that they also have significant financial barriers to going to the emergency room. So sometimes it's simply getting them into medical homes that works. You know, parents of young babies, especially firstborns, you know, the parents really are nervous. And in our transient civilization where, you know, young parents aren't always living next to their own parents and getting the advice of grandma, aunt, and uncle about what to do, they're really at a loss of what to do and tend to use the emergency room for, you know, the kid sneezed 3 times. The 1 to 13 is a similar thing. It's lack of information for parents. You know, we found out if you're a hospital employee, ED access is seen as a benefit. And then finally, young adults often don't really establish primary care relationships, even if they have a PCP assignment, because they don't see much value in it. And from somebody who's an advocate for patients in a medical home, you have to think about, you know, what does a 23-year-old really need in a medical home except a series of occasional emergencies. So they were making logical solutions as well. So what we learned from these interviews, shockingly, and I say that somewhat facetiously, is PCPs were not perceived as helpful to the patients. There was a perceived lack of access. Patients had either been trained or weren't ever informed that they could actually call their PCP. We always score really well when we're rated in the after-hours survey by CCHRI, but which is, you know, sham patients calling numbers and seeing what happens. But the real patients actually don't even know to call those numbers more often than not. When you talk to the PCPs about that, they don't see this as a problem. You know, they're saying my job is to see patients on my schedule, and it's not my job to control what my patients do outside of my office hours. But we also found out that half of the visits were occurring during office hours. And what we got from the patients, and what was really striking was, you know, patients protecting doctors, saying I didn't think it was appropriate to call. They had been trained to be told the doc's always too busy to take my call. And then the doctor staff turning people away, saying, you know, you call up saying I'm bleeding, and the answer is, well, we can get you in 3 weeks. So really, we began to get the sense that this is really a PCP problem, not a patient problem. Other lessons, you know, lacking of information and lack of confidence about what to do. I didn't know what else to do. I didn't know about whatever the service was there. They didn't know urgent care. And one of the other hospitals in the community has an ER and a thing that they call prompt care or express care. And it smells like urgent care, and it looks like an urgent care, and it, you know, tastes like an urgent care. But in fact, it's an emergency room with high price and copay. So, and by and large, patients didn't either use or know about the nurse care line. We also found out from patients is that when they called their PCP and they got someone on call who was from, you know, they didn't know who they were, very often they're from a different practice altogether and there's no shared EHR. They often simply hung up and went to the emergency room, and that seemed to happen about 75% of the time. Because what are the odds of a doc who doesn't know you, who doesn't have access to your records, taking the time to really sort out what's going on and bearing the liability in that situation? It's a lot easier to say, I think you should go to the emergency room. So, you know, we found that the large call pools that tend to still characterize medicine, despite the fact that they're hospitalists and people don't have to get up and go in all the time anymore, are not a help to patients after hours. So lesson 3, patients are oblivious about the cost or immune to it. At the hospital, they're actually rushed to the front of the line to get their care in the emergency room. or lack of understanding that ED and urgent care were different things, or great surprise when they went home and got a $100 bill or $50 bill, whatever the copay is from the emergency room, depending on the plan. They were shocked to get those bills. But they tend to be more willing to incur that bill than to try to be in debt to the practice itself. So it was seen as a debt by some people that they would never pay, and then eventually the hospital would write it off, whereas they were trying not to go into debt to their own practices, which I thought was pretty interesting too. So our conclusion out of all of this is patients are making the best choice available. There were no clearly established set of mutual expectations between patient practice. You know, simply what are you supposed to do after hours wasn't being taught to new patients or known by old patients and practices. That the primary care really didn't see decreasing waste as their job, and lo and behold, they're paid anyway. They also don't relate to their own issues around car repair. I find car repair is a really good example in one of those conversations with docs about access. You know, that if you want your oil changed, it's a big hassle to bring the car to the dealer. You know, you have to arrange transportation. They may have a van to drive you back to your workplace, and then you have to get picked up again later. They generally want the car for 8 hours, so you don't have the car all day. And that's how oil changes happen when you go to the dealership. When you go to the express lube shop, you're in and out in 20 minutes, and patients want something like that for urgent matters, and Humboldt County doesn't really make that possible for people. So, out of this information, we developed some strategies, and the first strategy we developed was try to provide patients with resource lists of what to do, very similar to what Michael did, though perhaps less attractive and less magnetic, because we didn't go to refrigerator magnets, though some of the practices actually have now. We sent out resource lists to people that we had discovered had been to the ED, and then followed up with the patients, but they weren't sent out. It was basically 2 to 4 months after the visit, and the patient said, "Thank you very much, this is a helpful list, but I could have used it 2 months ago." We did anecdotally note that 4 ED visits were avoided because we sent it out. And then because we also sent these lists and the list of the patients we sent it to the PCPs said, "Oh, that was helpful." So that was a good thing. So then we worked on trying to get data more quickly, and that meant going to the hospitals, and we succeeded and continue to succeed off and on with getting simultaneous notification from EDs. But it's the kind of data that goes away when someone goes out on pregnancy leave or gets promoted to a new job. It's hard to make this a permanent function, so it constantly takes working on relationship to get that data flowing in. So then we said, let's try calling the patients post-ED now that we know who they are, because we're getting these lists of follow-up the next day. And what we found out is that people are not really happy getting called by what they perceive as the health plan. And the IPA in the eyes of most of the patients is seen as the health plan. And we could only get response about 28% of the time, even leaving messages for callback. So that then led to the fourth strategy, which is let's try to involve the PCPs in these calls. And the question was, can a PCP office who gets all of the information of their previous day's patients call them all? And we started with a test in a single office, and then lo and behold, the patients called the PCP back, and they were able to reach 100% of the patients. And what again they heard, we heard this from the practices, the patients were really pleased to get called, and the calls, served multiple purposes, including, we saw you were in the emergency room, how are you? Do we need to see you right away? Is there anything we need to follow up? Did you have lab tests? Or do you have any confusion about medicines that were prescribed? Any way we can help? And it probably doesn't surprise anybody on the phone that such calls were really well received by the patients. So, what we were able to do with Stream 1 over the course of the 6 months of this initiative, once we were running, was drop ED visits, a fair amount. what's been hard to sustain in our little organization, which is part-time medical director and a staff that is being pulled in a million directions at once, is when the list falls apart from the emergency department to us, can we continue to get that going again? And the same person doing it has 27 other functions. So it really takes will, and it goes back to the will, that will concept I talked about earlier, to make this important. At one point, one of our chief operating officer, not the one we have currently, thought this was all a waste of time and pulled off the person who was responsible for making the calls. And then I discovered that a bit later and reversed it, but it sort of demoralized the department for a little while. So this is a model that works, but you have to, there is no end point. You have to keeping the information flowing. You have to keep sending the list of the patients out, getting the list to the docs. And then the question is, can you incentivize the docs to make the calls? And it's essentially making that seem like their work to them. And we've had, some success with that. We have a primary care renewal collaborative. That's a medical home collaborative, and we've seen, significant drops in ED rates in some of the practices who are in the medical home collaborative. And the rates vary from some practices in the 80 range, 80 visits per 1,000 patients per year, which is a really excellent number, to some practices over 400. And the practices that are over 400, lo and behold, are not the practices engaged in any of the improvement activities we're doing. So you can kind of see that playing out down the line. Can we pay, for patient-centered medical homes, they form for different reasons. But the doc reason for wanting to be a patient-centered medical home is they want to get paid more for primary care, and it's seen as a way to kind of rebalance the inequities in the payment system between specialist and primary care. Medical schools or residencies may want the patient-centered medical home because they want to increase the number of people going into patient-centered medical home. So you need to define what's the value of the medical home. From the purchaser point of view, which is the one who will be paying the extra money for primary care, it's really clear what they're looking for. And it's essentially the triple aim. They want to reduce ED visits and admissions because that's where the money is. And, an ED visit is about 20 times as expensive as a primary care visit for the same problem. And an urgent care visit is 4 times as expensive as a primary care visit for the same problem. So the best location is probably primary care, but it needs to be able to function as a lube shop, not just a dealership, a service department in a dealership. Payers also like improved quality scores and patient experience scores. Employers really don't want employee complaints. That's what they're most worried about. So what's the medical home about? And we found ourselves right in the middle of that in this ED question. So we needed to have those conversations that Michael talked about with the docs about, why is high ED rate important to the doc? And, so we went to comparative reporting, and we have a long tradition of completely unblinded reports. So we were able to show, here's the practice down the street, you know them, their rate is a quarter of yours. What are they doing differently than you're doing? And that data definitely changed behavior. And then changing patient behavior one patient at a time. And one of the first things we did in the Medical Home Collaborative was work on patient brochures that describe expectations on both sides. We will get you in the same or next day if you have a problem. Your job is to call us unless you're in a death or dying situation before you go, and give us a chance to tell you that it can wait till tomorrow and we guarantee you a slot in the morning. And so the brochures, I think, have a lot of potential. It turns out that what primary care is really about in the medical home is about a relationship. And what we find in the primary care community is that the primary care docs are sort of afraid of relationships. They're afraid of their patients having too good access to them. There's one doc in the community who will be unnamed who actually prides himself in only having one phone line, so not, to limit the number of calls that he gets during the day. And it's also his fax line. So if faxing is happening, no patient can get through. And he thinks that's a good way to control demand at the office. So, you're dealing with that kind of world in an IPA environment. But what we're really trying to sell in the collaborative is that cares about relationships. And there are a few practices, my own included, where I carry a cell phone and my patients can reach me 24/7. And what I find is they never abuse that. If I get 5 calls a month, it's a lot. And we've been able to persuade a few practices to do that. The great majority of the practices are still part of large call pools. So people calling after hours never talk to somebody that they know. And then the response is just what you expect, where patients show up into emergency room. The question then is, how do you begin to reward relationship-based care and disincentivize non-relationship-based care? There are also patients who obviously need more than a normal practice can supply, and that's a complex care initiative that we're doing called Priority Care, where we're providing a nurse that helps augment that relationship. And as the first person called, and the nurse is on call until 10 o'clock at night anyway, so it deals with that section between 5 and 10. What's interesting is that when we talk to the patients, it didn't seem like after hours, which is always everybody's first go-to, Saturday hours and after hours, that didn't seem to be why patients were showing up in the emergency room. It was much more that the offices were turning people away when they called than it was, need to go at different times. And that was a kind of a surprise to us, because everybody thinks that, extended hours is the answer. So, what we show in the medical and collaborative is, and I would, the doc would be the one sitting on the exam table, and I would be the one with the clipboard, though that guy has a lot more hair than I have, would be, I'm afraid you've had a paradigm shift, and that's what we're really trying to build in this community, is a primary care paradigm shift. And the patients are not the problem, and they're part of the solution, but they simply don't know what to do. So I think that's the end of what I have, and I think we can go on from here. And there's, I don't know how you want to handle questions.
Yeah, great. Thanks, Ellen. We're right up against 1:30 now, so just in the interest of time, we do have one announcement, an upcoming event relevant to this topic that Giuliano, who's on the phone, is going to announce, and then we do have a question in. So if anyone needs to cut off, the session will be recorded and posted on the website, and just to let folks know. Giovanni, you should be okay now if you want to make your announcement.
Hi, great. Thank you. Can you hear me?
Yep.
Okay, great. I just wanted to let folks know this is Giovanna from the California Quality Collaborative, and Dr. Weiss at the beginning in his presentation referred to Howard Beckman's approach several times. We do actually have a CIN-sponsored Howard Beckman workshop on how to engage physicians in change that goes through the techniques that Dr. Weiss spoke of, how to develop reports, how to initiate those conversations, how to do focus groups, and so on. It's coming up on October 13th in Oakland, and I believe that Lori just chatted to everybody. There's a link to a description of the program and a link also to the registration page. And you can also visit our website, calquality.org, for more information. And we do have about 12 spots left in that workshop.
And this is Alan, and I just really strongly urge everybody to consider attending that. Howard, I couldn't second more what Michael said about the value of Howard's approach. And what you're going to find out is he basically uses the same approaches that work well with patients, such as motivational interviewing, and does a lot of listening and presents data that is solid data. And relies on the professionality of the people he's talking to, and when you treat people as professionals, you tend to get professional behavior back, and I can't recommend that more strongly. There's one question which I can take that was sent by Jose Arevalo, my old residency mate from many years ago. I won't embarrass either of us with how many years, which is about incentives to make the call. And And what we've been doing, but the docs are not together enough even to really bill it, except occasionally, is we were paying $25 a call if they documented having made a call to a patient post-ER. What we do know is a lot of the practices are in fact making these calls and not billing it. The satisfaction of the patients, and we measure a lot of stuff, and we even publicly report a lot of doctor level data in our community. The feedback from the patients and the joy of the practice in having happy patients has seemed to trump the need to pay people differently. But I would like to get to a place where the capitation we pay PCPs is largely determined by certain behaviors and patient experience, and we're not really there yet. We're still mostly paying people the same, and have a P for P bonus, which includes ED, but is sort of outside of the normal payment scheme. And I would like to pay people month by month based on their value rather than just the number of patients they have signed up, and we really haven't gotten there as a community yet. But I think incentives in the long run are really important, and it's just hard to have incentives be effective when you only manage 5% of the population in a community. I don't know if that helps.
Great, thanks so much. I think we're, because of the time, we're going to have to end things, but just a reminder for anyone, the slides and the recording will be posted on the CIN website in about a week, and next month's webinar will be on care transitions, so we hope that many of you can join that as well. Thanks a lot.
And care transitions and this have a lot in common, this work, so those of you interested in this should definitely sign up for that as well.